Welcome all to this second backgrounds pathology lecture. I seem to have a bit of echo. This is the second of our Pathology Grand Round lectures, which is sponsored by the Pathological Society and the Shanks Foundation. It gives me great pleasure today to introduce our speaker, who's Dr. David Huntsman. He's a pathologist and clinical molecular geneticist at the University of British Columbia in Canada, and he is the Canadian Research Chair in Molecular and Genomic Pathology. He specializes in ovarian cancer research, and he directs OVCARE, which is British Columbia's multidisciplinary ovarian cancer research team. And he today will be speaking about various cancer histiotypes and how they're products of specific interactions between the tumor cells, mutation, and the microenvironment. And he'll not only use ovarian cancer as examples of this topic, but also endometrial cancers and also endometriosis. So without further ado, I'd like very much to welcome David, who will take us through this wonderful lecture. And there is an opportunity at the end for Q&A, and I will be coordinating them at the end. Thank you very much, David.
Have we successfully shared screen here? Okay, fantastic. And can you hear me? Okay,
Again.
brilliant. So first of all, it's a great honor to be asked to present today. I want to thank the Pathological Society in particular for guiding and sponsoring the Journal of Pathology and its more clinically minded younger sibling. And these are fantastic journals, and they provide a really strong, perhaps the best connection between the science that underpins pathology and the practice of pathology that exists globally. And so I cherish these journals, and I hope you're all proud of them and use them to their potential. So I'm going to be using ovarian cancer as an example, but I'm hoping some of the things I talk about will have relevance to you in no matter what diseases you study or specialize in. So first of all, I'd like to dedicate this talk to a friend who worked with you and your community for many, many years. Then she moved to Vancouver. And very sadly, as you probably all know, Navina was diagnosed with pancreatic cancer shortly after her arrival in Vancouver. And just the year she worked with us, she really became a huge part of our professional and social lives, and then passed away around a year ago. And when I look at really worthy international initiatives that include gynecologic pathology, Navina was always central in those. And so I want to thank her and acknowledge what she meant to us here, but also it's probably a shadow to what she meant to you all because you worked with her for so long. I have no real commercial disclosures. I'll be talking about questions and opportunities. And so a lot of what I'm going to be showing you is half cooked. In fact, all three stories I'll share are developing, and I'm always open for collaboration. And my research, like yours, is a team sport, and I couldn't do any of this without my colleagues and trainees. We really do act as a team. Several years ago, we formed something called the Gynae Cancer Initiative with a goal of reducing death and suffering from these cancers by 50%. And that's across our population. And I found that by doing this, it really changed everything about the way I engage in research. I mean, I had to sort of build a team so that we could impact from prevention, diagnosis through survivorship. So we had to really engage people to get into survivorship research as it applies to gynecologic cancers, because we can't achieve our goal without that. We have to look at all cancers, which has created opportunities for junior colleagues like Lin Hong, who studies cancer of the vulva, and we have to impact our entire population. So I had to try to keep my work from becoming too geeky and focus on stuff within the lab. We also needed to build out our team and had to work with a lot of stakeholders, including the indigenous communities of BC, which is something which I was never really prepared or trained for, but has been a great learning experience. This is what one of the things which drew me to ovarian cancer, and it's the horrifically stable and awful survival rates, looking at 1, 3, and 5-year survival rates in BC, which are similar to other places. And it's an area where there was great need for improvement when I started to engage in this 20 years ago or so. The other reason is when I was in my pathology training in the early 90s, ovarian cancers were wondrous. There were so many different flavors which you could diagnose with different cells of origin. And these actually reflected distinct biology, of course. And now we view high-grade serous ovarian cancers as being, we know it's the most aneuploid of all cancers. It's the canonical P53 cancer with BRCA mutations being important in a minority and PARP inhibitors being very useful in a slightly larger group. Small cell hypercalcemic cancers are the prototypical SWI/SNF-driven tumors, insanely aggressive but diploid. Sertoli Leydig cell tumors have perhaps the most stunning example of a differentiation defect we can see across neoplasia. And clear cell cancers are defined by metabolic abnormalities, as they're stuck filled with glycogen. So there's so much here to dig into. But back when I was in my training, we would see these different types of cancers and we were taught to recognize them. But a lot of the diagnoses we made had no real clinical significance. And this is because all the ovarian cancers were treated the same way, no matter what they were. And the problem is that the old classification system where tumors were put on a grid with histotype and grade just didn't work. It wasn't reproducible, so the clinicians couldn't use it. So with my colleague Blake and then other groups, such as Group in Hopkins, we kind of collapsed this into a usable classification system where there are 5 subtypes of carcinoma. And this obviously works. These can be diagnosed with 95% accuracy by community pathologists. And in ovarian cancers, all analysis comes after histotyping. Histotyping, the 1850s kind of technology, is still vital for the care of ovarian cancer and also the control and research into this disease. So these are distinct diseases, and every way you can define a distinct disease, they're distinct diseases, from presentation, through outcome, through biomarkers, response to therapy. And so our group coalesced around the idea that if we treat them as distinct diseases in research, we will make progress clinically. So genomics offers a substrata of information, and it has little value outside the context of histotype. And it's so different from what goes on in the uterus, where histopathology essentially does not work. And I love this paper because you have some of the best pathologists in the world agreeing, but they all disagree about how to diagnose high-grade endometrial cancers. A solution was offered by the TCGA, and this is around 20 years ago, oh, sorry, 10 years ago now. And this is probably the most important of all the many TCGA papers because it's actually provided something which was immediately useful, which was the identification, but there were of about 10% of cases which were hypermutated but had stunningly good outcomes. Our group, working in parallel with the researchers in Oxford, London, elsewhere in the UK, and of course in Leiden, took that classification system and made it into something workable. We call our version PROMISE. And Jessica McAlpine, along with Aline Tahouk, who's a statistician, have been championing in this. And my lab, along with Blake, we provide laboratory support and do the analysis of the tumors for them. And this classification system has shown to work in basically every population it's been looked at, and has worked through the Institute of Medicine's roadmap for biomarker development, and is now used clinically in BC and in other places. Histotyping, of course, still exists, but because the histotypes are spread across these different molecular subtypes, it's really of secondary importance. So whereas in ovarian cancer, histotype comes first and molecular comes secondary, in endometrial cancer, this is inverted. And the unusual histotypes, mesonephric carcinomas, still provide useful information in the NSMP group, but aren't that useful as a standalone. So this really moved quickly from discovery through to being embedded into clinical guidelines. And one could argue, but maybe it's even moved too quickly because the community isn't ready for this. And there's large parts of the United States which doesn't really use it, even though it's in the guidelines. So this has changed everything for endometrial cancer. It's provided a platform where we can study endometrial cancers in different places, share results, and know that we're talking about the same disease. We can expect fine-tuning and substratification, particularly in the NSMP group, which is a bit of a garbage bin right now. But it does allow us to ask sharper questions and to focus efforts on drug development for the patients who need it and clinical trials for those subpopulations, and also to address really important questions like such as, do differences in the subtypes distribution explain differences in outcomes in different ethnic groups, such as African Americans, and or are the subtypes behaving differently in those racial groups? And so it's there's really it's opened up a lot of doors. And I think this is a disease where justifiably many people are studying it right now, and that we can expect great progress, and a lot of that progress led by the pathology community. So back to ovarian cancer. Around 2008, we got access to Selecta sequences, which became Illumina. And we posited that the different subtypes of ovarian cancer would all be kind of explained away by different mutations. And we found key mutations in several subtypes of ovarian cancer. And we were rather filled with hubris at the time and thought, wow, we've got the answers here. And I apologize to anyone who had to suffer through my presentations then. But of course, mutations don't really explain what's going on. They're valuable information, but outside of the other things going on in a cancer, they're often useless. We know that mutations are often found in normal tissues. So particularly the uterus is quite dramatic in that KRAS mutations are more common in the uterine epithelium of older women than they are in the cancers that come from that organ. So mutations themselves don't tell you what's going on. Also, some mutations, such as those in the switch-NIF complex, can't be understood in any way outside of the cell context in which they occur. And I say this with an understanding, but most papers which study them are done in a very generic kind of way, which can't possibly translate. And this is because cell context is defined and maintained by the epigenome, and therefore it makes sense that the impact of mutations and drugs that perturb the epigenome are going to be very self-context specific. So we've changed the way we think about this, and now for the last few years, we've been focusing on cancers as being the endpoints of very distinct oncogenic journeys. Like any journey, like a hike, the things which determine where you end up, like the cancer, where you start, the cell of origin, the terrain you cross, the microenvironment, and what happens along the way, the mutations. And cancers sort of sit in the middle of these. And for most cancers, if you change any one of these three variables, you end up with a completely different entity. And so all three are important and have to be considered. This is like sort of the simplified pathologic version of hallmarks. So our group focuses on trying to understand these oncogenic journeys for several different cancer types, hoping that it will lead to prevention and treatment opportunities. So starting with where cancers come from. So this is an old textbook image of where ovarian cancers come from, and obviously it's quite logical. They're carcinomas, so they must come from epithelium, so they came from ovarian surface epithelium. And This seemed problematic at the time to most pathologists because mucinous carcinomas often came from mucinous borderline tumors. Low-grade serous carcinomas came from serous borderline tumors, and clear cell and endometrial carcinomas often came from endometriosis. However, that was the belief until Louis Debeau wrote an interesting editorial which had the right idea but the wrong conclusions. Van Jurgen Peek identified what we now call stick lesions in the fallopian tubes of women with BRCA mutations. There's been a lot of work on stick lesions, and including a lot of great work done in the UK. And of course, these lesions are, even though they're just a millimeter across, they are potentially lethal because when they shed cells, those cells have direct access to the ovary and the peritoneal cavity. And we believe that when the cells shed from stick lesions, they can be dormant for many years before cancer presents. And we see this in patients with BRCA mutations who, I think the record is 9 years after salpingectomy, a cancer arose and a stick lesion was then found in the fallopian tube which shared a p53 mutation. There are still people who believe that some of these cancers come from ovarian surface epithelium. And this comes from mouse models where you can mutate ovarian surface epithelium and sort of turn it into something like a high-grade serous carcinoma of the ovary, and gene expression studies as well. The evidence for sticks comes from not just clinical insights, but also genomics with simple mutational analysis, looking at p53 mutations, more complex analysis, looking at clonal trajectories. And it would appear now that the majority, most people believe that most high-grade serous carcinomas of what we used to call high-grade serous carcinomas of the ovary actually start in the fallopian tube. Now, the stick lesions aren't all the same, and there's very nice work from both Yiming Xingyi's group in Hopkins and also Ian McNeish and colleagues in London, which suggest that some stick lesions are aneuploid and they're much more aggressive than other stick lesions which look similar. And so there may be some role in subtyping of stick lesions in the future to determine which patients need more aggressive management, because for some patients with stick lesions, they do quite poorly and obviously need to be managed more aggressively. This is hard to study in mice because of the anatomic differences, because mice have a bursa which goes over their ovaries. And if humans had this, and then ovarian cancer wouldn't be such a big deal clinically because you'll catch more stage 1 cancers. But it does mean that the clinical course of these cancers is very different in mouse models. So we rely a lot on human pathology type research to sort out what's going on. Many questions. What follow-up is required? Can they be detected by screening? And will that even suffice? If you detect a stick and it's already shed cells, have you helped a patient? For women with BRCA mutations, can you remove fallopian tubes first and then ovaries afterwards to prevent premature menopause, yet provide cancer prevention? This has been studied in large international observational studies. But our group focused on something a little different, which is, can we use this information to help the general population? The 80% of women who develop high-grade serous cancers don't have a BRCA1 or 2 mutation. What can we do about those? We had a very imaginative head of gynecologic oncologist, Diane Miller, and she said, well, what we need to do is remove fallopian tubes at time of surgeries where we can. And we call this opportunistic salpingectomy. So there's an opportunity from a hysterectomy being done for fibroids or abnormal bleeding, or tubal ligations being done, and the surgeon should offer the opportunity of the woman to have her fallopian tubes removed. We started doing this in 2010. We had a sense it was safe, but we did not have any efficacy data. And I'll show you data on safety, efficacy, and uptake. Very soon after our declaration that we were going to do this, our national body, the Gynaecologic Oncologists Canada, started to suggest this, but it should be mentioned. But this recommendation, like most of professional society recommendations, are still kind of warm, but not very strongly worded, because efficacy data didn't exist. But I think that that is turning now because our group and others are showing efficacy. So opportunistic salpingectomy, many questions. Is it possible to change practice? Is it safe? Will it work, and to what degree? And so with Gillian Handley, who's pictured here, is a brilliant health economist who's in our research team, I formed something called the Ovarian Cancer Observatory. And we have funding locally from Canadian organizations, the Department of Defense in the US, and also Ovarian Cancer Research Alliance from America to support this work. Can we change practice? So in 2008, fallopian tubes were only removed 0.5% of the time at time of surgery. Now we're up to 82% in 2019. In hysterectomy, it was 8%, now to 75%. It takes us a while to get data from our administrative databases, and we hope this number is still growing. Safety. We see no difference in these procedures in terms of immediate safety concerns, but there really was a concern raised by serious epidemiologists in the States who asked whether removing fallopian tubes at time of these surgeries could cause some increase in premature menopause. Anatomically, that does not make much sense, but it's a very serious consideration. We can find no increase in the use of hormone replacement therapy or changes in timing for the first doctor's visit for menopausal symptoms in women who have fallopian tubes removed for these surgeries as opposed to those who don't. So we see no signal there at all. In terms of efficacy, there have been population-based studies, but in these studies, they actually have no idea why the fallopian tubes were removed. And so some of these women were probably high risk, and but all of these studies show some measure of risk reduction for bilateral salpingectomy. There is one awful study actually from Canada where they claimed there was no difference, but they included unilateral salpingectomy, which seems to have a very high risk for ovarian cancer. But bilateral salpingectomy does decrease the risk for ovarian cancer. So we don't expect opportunistic salpingectomy will prevent all ovarian carcinomas for a whole bunch of reasons. So we would never say that this would eradicate risk in an individual who has this surgical practice change. There can be transposed fallopian tube epithelium on the ovary. There can be pre-existing endometriosis or other field defects. There's other origins, perhaps from mucinous carcinomas or low-grade serous carcinomas, but we really don't know where they come from. But also, these are low-risk procedures, and we don't expect the surgeons to spend much time doing this. And there will be bits of fallopian tube left behind. This is an image from Brooke Howard from a patient who underwent a salpingectomy, then later had a oophorectomy for a BRCA mutation. And Brooke found a huge chunk of fimbria stuck onto the ovary. And this is in a high-risk scenario. So I can imagine in a low-risk scenario, this will not be an uncommon finding. It doesn't mean that this isn't worth doing, though. So we published in JAMA Open Network our first efficacy data from our population. This is an update up to 2020, and we hope to get 2022 data soon. So basically, we modeled the expected frequency of these cancers based on what we see in the women who had the control procedures, which would be usual tubal ligation or usual hysterectomy without fallopian tubes removed. And what we can see here in the opportunistic salpingectomy group, though, it says there's less than 5 cancer events. Now, our administrative data stewards do not allow us to report a number which is between 1 and 5. So we can't show that number, which is strange, but those are the rules. This is the hazard ratio, 0.22. So it's a significant reduction. We wanted to make sure that we don't have a confounder here, but the most all the kind of risk factors and everything else are pretty very, very similar between the women who have these different surgeries. So we do not believe this is confounded. We did also want to make sure we didn't have some sort of healthy population effect where the women who are getting these procedures are more into health. And so we looked at other cancers, colon cancer and breast cancer in particular. This is the breast cancer risk, and we can see that opportunistic salpingectomy does nothing for breast cancer risk. It does nothing for colon cancer risk, so we don't think this is a healthy cohort effect. So will it work and to what degree? It does seem to be working, but it would prevent cancers or precancerous cells from spreading from or through the ovary, wouldn't prevent transformation of pre-existing endosalpingiosis, endometriosis, or ovarian surface epithelium. Fallopian tube removal should not prevent ovarian-derived carcinomas. And so if there are a large number of OSC-derived cancers, we won't be doing anything to prevent those. And we'd expect such cancers to dominate over fallopian tube-derived cancers if we look at women with who develop cancer after their fallopian tubes have been removed. And so we set about to study this in two ways. One is looking through our population-based data, and I showed some data from that. And we're now working with Mayo Clinic and Kaiser Permanente and other places trying to get more data. But also we have another way of doing it. And if any of you would like to participate in this, I'd love to hear from you. So this is by case-based ascertainment. So we ask pathologists, but if they ever see an ovarian cancer come, into their world, or if they can search through their data and find ovarian cancers which are diagnosed in women who did not have fallopian tubes at time of presentation, we want to hear about it. And we collect data using a REDCat database, histology data, some demographic data. We remove cases whether there's a known BRCA mutation or ovaries were removed as well. And then we can see how ovarian removal of fallopian tubes impacts the cancer. So on the left is the usual kind of subtype distribution, which is seen for ovarian carcinomas. This is the Vancouver data, and when we look in other places, it's very similar. Of course, the exception being in Japan, where they have more clear cell carcinomas. If we modeled an 80% reduction of high-grade serous carcinoma and a 40% reduction of clear cell and endometrioid carcinomas, you end up with the pie chart at the top. High-grade serous carcinoma would still curiously be the most common cancer because the second and third most common types are also suppressed a bit, but the pie chart looks very different. Now, it turns out that cancers which occur after fallopian tube removal are very rare, but this is what we got so far. So this is our pie chart. And I think like anyone looking at this would have to agree, but this is dramatically different. High-grade serous carcinomas are no longer the dominant subtype. Removing fallopian tubes does, great mischief to the development of these cancers. And it works. We do not have population-based data showing that this saves lives yet. But since the procedures can be done with no morbidity or mortality associated with them, it's because they're opportunistic, we believe that the health economic benefits, which we actually had calculated before based on a much more conservative model and looked really good, are near infinite at this point. So to what degree can we reduce the incidence of ovarian cancer in our population, not thinking about the individuals who we help, but across the whole population? And here there is a trend for both these procedures where we would want to do the opportunistic salpingectomies are decreasing in number. And so our group and others are trying to see whether we can extend this to other surgeries. So we're working with GI surgeons to see if they can bring opportunistic salpingectomy into the procedures they do on women who may not want their fallopian tubes anymore. So this is done with urologists and general surgeons, and there's several studies around the world. So opportunistic salpingectomy is safe and effective. We need to expand the opportunities to other pelvic surgeries. And we're starting to consider not BSO, but targeted risk-reducing sapropingectomy in women who can be identified who have an intermediate risk for ovarian cancer because of their genotype, using GWAS-type SNPs and other epidemiologic risk factors. But that's an area where the health economics really will need to get done, because that we don't know how whether that's going to add up to providing benefits. But I note that this all started by research from a junior pathologist, Jürgen Peek, who was and just over 20 years ago, and it's led to tremendous opportunities to save lives. In BC, like in other places, the incidence of ovarian cancer is decreasing with time. And this is largely due to the tremendous effect, legacy effect of birth control pills on the reduction of ovarian cancer. And we still actually don't know how this happens. If you look it up in textbooks, it says birth control pills prevent the wounding of the ovarian surface epithelium. But that's not where these cancers come from. We see this across, the reduction is across multiple subtypes other than mucinous. But we have a big worry because in North America, presumably in the UK as well, birth control usage has been greatly reduced, and more women are using LNG IUDs instead. And we have no idea. We don't think those are going to provide the same protection, but we don't know, and largely because we don't even understand how birth control pills worked. So we may be setting ourselves up for some trouble in terms of more ovarian cancers. We are addressing this by trying to obtain ovarian cancers from members of our population who have opportunistic sapropingectomy, who either have IUD exposure, ovarian contraceptive pill exposure, or neither. And we're going to be using spatial genomics to see if we can see the difference. And this is really unfinished, not even really done work. But I just show this because if there are any trainees watching this, the spatial genomics takes us from the looking at things and saying, this is what it is, and we give it a name because it looks like this, to actually starting to see what things actually are down the microscope. It's just amazing. So there was a study in bioRxiv which used single cell analysis and showed there were 3 types of secretory cells in the fallopian tube. We were able to very easily recapitulate this using xenium analysis on normal fallopian tubes. And we can see there are 3 types of secretory cells. There's a rare blue type, which is the proliferative cells, which we can only see in the proliferative phase and not really in the inactive or secretory phase. And there are 2 other subtypes which have some really interesting differences between them. And so we're going to be tracking these across those populations. And this does, again, for pathology trainees, this really, these methods open up tremendous opportunities to really understand what the amazing kind of features which have been used for so long really mean, and what they can tell us about the biology of the underlying entities you're studying. So that was cell of origin, considering mutation. We did find mutations in several rare types of cancers, including this mutation in granulosa cell tumors. And we thought we'd been very clever and we would have a biologically informed therapy quickly. But sadly, after 20-something years, oh, sorry, not quite 20, 15 years, there's nothing because there's no model system. So without a model system, you can't really go from a discovery of a mutation towards having a rational treatment. And so progress has been really, really slow. Sertoli cell tumors we studied around the same time. And when we sequenced the tumors, we found that the tumors often had very specific mutations in DICER1, the microRNA processing gene. And DICER munches up pre-microRNAs. It's a bottom and a top set of jaws. And if you have one of these mutations, you can only partially process microRNAs. So the bottom strand, the 3' strands get processed normally, but there's no 5' strand targeting. So these mutations occur in the background of loss of the other allele, which can be inherited. And another figure just showing how we can do 3' strand targeting, but not 5' strand targeting if you have these mutations. If you're born with one of these, with a DICER mutation, a nonsense mutation, you're susceptible to get a range of different cancers, including pleural pulmonary blastomas, kidney cancers, and a range of gynecologic cancers, as well as thyroid, goiter, which is very interesting as well. The cancers often look rather alike, and Gynaecologic with Will Folks had an article which said these are probably all the same cancer, and I certainly agree. When you look at them, they all have a lot of the same features. When they occur near the brain, there's no epithelium because there isn't any epithelium to drag along. The epithelium in our work seems to be non-neoplastic, but there is some strong paracrine interaction between epithelium and stroma. So there were no good models for this. There's no cell lines. So we worked for years to develop a genetically true mouse model. We wanted to study Sertoli Leydig cell tumors. So we started with a model which was based on the anti-Müllerian hormone. And so this would be, the mutations would be expressed in gynae tissues. And what we ended up with was with a very highly penetrant adenosarcoma phenotype. But it wasn't really a very workable model because the mice would go from healthy to really, really sick too fast to really study them. So we took a step back and worked with a colleague who studies mesenchymal stem cells and a particular gene called HIC1. And he'd shown that you could, if you put synovial sarcoma gene fusion into HIC1 cells, mice get synovial sarcomas. So we posited if we put the DICER mutations into these cells, they would get a range of different DICER tumors, including pleural pulmonary blastomas. What we saw was an incredibly like long latency but high penetrance for renal cancers. And these mice get all three renal tumor types you see in DICER1 syndrome. They get cystic nephromas, they get Wilms-like tumors, and anaplastic sarcomas, including muscle differentiation, and they look identical to their human counterparts, mouse at bottom, human on top. When we look at the tumors, we have a lineage tracing marker in this. We can see that the epithelium is actually not part of the tumor. And we've shown this in all of our cancers. The epithelium is a drag along. And we think this is probably the case in human tumors too, but it's easy to study some things in a mouse. As these human cancers with DICER1 syndrome progress, they tend to acquire P53 and/or KRAS mutations. And we see the same thing in our mouse tumors, which is very gratifying because it really does recapitulate the disease because we see the same secondary mutations, including in some cases, rather than KRAS mutation, we get KRAS amplification, showing how important it is because it's strongly selected for. We have syngenetic models here, and we are using them to test different treatments. If anyone else is studying this or interested in it, we'd love to work with them. And we do see something curious in our tumors, that they seem to, as an obligate feature, seem to have gain of chromosome 1 when the tumors arise, which can sometimes be lost later on. And we see this in almost all of the cancers. And this is unexplained. And if there's anyone who has ideas about it, I'd love to hear from them. But we're trying to work this out. There was a paper in Cancer Cell suggesting you could see this in another cancer type from mesenchymal cells. And so we think this may be a mesenchymal specific feature in mice. We don't know if there's a human equivalent. We've started to use spatial genomics to look at these. And when we look at the normal kidneys, we can see occasional little orange cells, which are universal fibroblasts, the earliest fibroblast precursors you can have. As when we look at our early lesions, so the precancerous lesions in the mice, we can see these malignant-looking fibroblastic cells. We see quite a lot of these universal fibroblasts. As the tumor progresses towards anaplastic sarcoma, they seem to become lost. We believe these are the precursor cells, and the reason why we only see kidney cancers in this cancer is that these cells are still present in the kidney after birth when we activate the transgene, but have gone in the lung already. So we're trying to do an in utero activation now. Our trajectory analysis, both in human and in mice models, shows that these do seem to be the cells where all the other cell types come from these universal fibroblasts in the cancer. So we think these are the precursor cells, but really want to understand why we're seeing kidney tumors and not these other cancers. there's the desperate need for treatment for these Dicer 1 sarcomas, particularly when they recur, because nothing works. And we hope we can translate this into some kind of new treatment opportunities as quickly as possible. For the last few minutes, I'm going to talk about microenvironment. I think the endometriotic cyst is one of the most, it's the Mount Everest of microenvironments in terms of how harsh and difficult it must be for a cell to survive, because you're bathed in reactive oxygen species and other kind of toxic debris. And 2 cancers come from endometriotic cysts, and these happen in the ovary much more than any place else. Clear cell and endometrioid cancers. We initially thought that genomics would explain why we get these 2 different cancers, but there isn't a single mutation type or mutation class which is exclusive to one and not seen in the other. So mutations really don't explain why these cancers are so different from each other. So we focused on how these 2 different lesions could come from the same precursor. We got a bit lucky because we did a proteomic screen on these cancer types and noticed there was a protein called cystothionine gamma lyase, which was enriched in clear cell cancers as opposed to endometrioid and high-grade serous. This is a very interesting protein because it's key for the production of glutathione, which helps cells survive in places like a endometriotic cyst. Unlike a lot of the things we identify through proteomic screens, there is a good antibody for CTH. We were able to show, yes, indeed, it does mark clear cell carcinomas of ovary and endometrium. And curiously, it marks ciliated cells in normal tissues. And this is an endometriotic cyst where we can see these beautiful ciliated cells marked by CTH. In a case of clear cell cancer coming from endometriotic cysts, this is from a JPAC paper from a couple of years ago, we see the cancer is marked by CTH, borderline tumor is, but also the endometriosis adjacent to it. With clear endometrioid cancers, we see ER expression in all 3, but no CTH. We started to consider that this may reflect kind of a cell of origin effect, in that the cells which clear cell cancers come from survive in an endometriotic cyst because they can express CTH, and they carry this forward. We've done a lot of work on this. This work's under review right now, where we're able to show that if you take endometrial epithelial-derived organoids, which we expose them to hostile conditions, including endometriotic cyst content, they start expressing CTH. If you knock out CTH, they don't survive as well. We've done a lot of work in vivo showing that when we knock out CTH, these cells do not grow as well. They don't form metastasis. Even though they still express H and F1 beta, they're still clear cell cancer cells. Just showing them at the bottom, the metastasis and the CTH knockout cells, the top are the CTH expressing cells, and certainly there's a difference in the number and the size of the metastatic lesions. Curiously, though, when we look at the metastasis themselves, they express a high Ki67 level in the CTH knockout, so it's paradoxical. These cells are churning over, but they're dying even faster, and they're not forming metastasis. So we believe CTH is going to be a good therapeutic target because it's an enzyme in this cancer type, and are working to develop new drugs to try to target this enzyme. And trying to ask the question, what is CTH doing in these tumors? We found something quite curious, that CTH seems to be required for the expression of HIF1 alpha, which is a key feature of clear cell carcinomas of the ovary. But this is not a transcriptional event. Indeed, when you knock out CTH, you see less HIF1 alpha, but you see protein, but you see a higher level of message. It's a translational event. So somehow CTH is involved in the translation of HIF1 alpha message into protein. This is called a moonlighting function because we have an enzyme which does its business. It produces H2S and glutathione, but it also may do something else. We've shown that it actually binds to HIF1 alpha message and also has strong binding to the translational machinery in the cell, in particular EIF4E. And I think that this kind of idea that you have these well-known proteins which do something in a cell and suddenly you can find they do something completely different is coming out more and more in the literature. So a model for how this operates is that cells have to survive in this endometriotic cyst, and they start expressing CTH, which is also expressed in secretory endometrial cells, and they express it because they can express it, they survive, and they carry this forward because it gives them an advantage as a tumor cell. It helps them metastasize and through the expression of HIF-1 alpha. And we're working to, we have some compounds which aren't drugs yet, they're not even proto-drugs, which seem to be able to hit CTH and turn off this function, and we're looking to develop these as potential treatments for clear cell cancer. So I think I've given examples of the importance of cell of origin, which is really kind of the bread and butter of pathologists, but also where things happen, which we also think about the context, and mutations, which are considered perhaps part of molecular pathology, but I don't believe molecular pathology exists or should be allowed to exist. I think it's all pathology. And how when we think about these three features, it offers a doorway to better understand cancers and to do something about them through trying to develop prevention strategies and move towards developing treatments as well. I'd like to thank my team and funders, of course, for this work, and collaborators as well. And we'll be very happy to address questions which you may have at this point in time. So thank you for your attention. And
thank you very much, David. That was fantastic. I certainly learned a lot. It was a brilliant overview of, yeah, and update on these tumors arising, fallopian tube, ovary, etc. So I already have a question here in the question Q&A, and it's from James Morris. Do stromal bacteria have a role in this story? F. nucleatum is found in the stroma of endometriosis, ?
So I don't know about, I do not know the answer to that question. I think it is quite possible they could. It could be that they are sort of necessary but not sufficient somehow. And in particular, when we look at the effect of birth control pills on the development of high-grade serous ovarian cancers, perhaps some changes in microenvironment may be part of the story. Even though as individuals, those engaged in actually research and pathology, we tend to be some of the least trendy people around. When new ideas come up, everyone tends to coalesce around them, and they're presented as explanations for everything, and then we move to some more kind of moderate, sensible ground. I'm sure there's a role here. I don't know what it is.
Right.
And so it could play a role. And I told a story of how I think clear cell cancers come from these cysts. I have no idea how endometrioid carcinomas arise from them. What protects those cells? Because when you do compare endometrioid carcinomas to the other carcinoma histiotypes, they're really amazing for being so bland. They're always defined by what's not there.
Mm-hmm.
So it could be there's a role there.
Great, thank you. Another question, Dharani Hapangama, who's a gynecological oncologist who also has her own research group. She says, fantastic talk, thank you. Do you think the mutational burden on different endometriosis lesions are the same, or are they different? And then also, that's one question. Also, what are your thoughts about similarities or differences between endometriosis and adenomyosis?
I think that all the differences between endometriosis and adenomyosis can be explained by where the lesions are. So if you have endometriosis in the muscle, it is adenomyosis, and that can cause different symptomatology. Like deep infiltrating endometriosis, adenomyosis rarely transforms into cancer. So I do think all the evidence suggests adenomyosis is maybe a stage of endometriosis. For the first question, we did have a paper actually, again, in Journal of Pathology several years ago, where we looked at clear cell carcinomas, and we looked at the endometriotic lesion, and we did full genome sequencing on these. And you found all the mutations we could identify in the cancers were already in the endometriosis adjacent to the cancers. So there was a very high mutational burden in those lesions. People have looked for, our group and others, mutations in the endometriosis not associated with cancers. There are some mutation types, like KRAS, PTEN, PI3 kinase, you see quite commonly, and others which may not be primary events, but occur slightly later in the progression to cancer, like ARID1A, which are much, much rarer in endometriosis, which isn't directly associated with a cancer. So the types of mutations seem to be important, and also the number of different mutations. And you can see, if you screen normal uteri, you can see occasional glands which have lost mismatch repair, particularly in hysterectomies from women with Lynch syndrome. So we know that some will have lost mismatch repair or have other fundamental abnormalities which lead to the acquisition of mutations as well.
Thank you.
But the ovary seems to be particularly important, because there was a large study from Finland which didn't find that endometriosis outside of the ovary had no association with cancer. However, of course, I know that everybody here who looks at these cancers will have seen a very rare cancer occurring from incisional endometriosis or outside of the ovary, but it just seems to be the ovary is microenvironment is some sort of near requisite feature in the development of cancer from endometriosis.
Thank you very much. So Mark Ahrens, he asks, what are your thoughts on the origin of primary peritoneal serous carcinoma?
So when fallopian tube was first discussed as source of high-grade serous carcinomas, people felt that endosomal pigiosis may be as important as endometriosis as a source of cancers. Studies sequencing endosomal pigiosis has found that the mutations which seem to be more associated with low-grade serous cancers. I believe that, and again, this is now straying from sort of science, but that most what we used to call primary peritoneal cancers came from the fallopian tube, and the sticks were missed. We have 2 cases in our ovarian cancer observatory where after fallopian tube removal, cancers occurred. And in both cases, when we went back and looked, we found sticks. Most cases, we can't go back and look, because when the fallopian tubes were processed, because they're low risk, they were minimally sampled. And so there may be something called primary peritoneal carcinoma, but I believe it is very, very rare. And removing fallopian tubes will not prevent a cancer arising from cells which have been shed from a pre-existing stick. And of course, if it's a low-risk fallopian tube, you can't expect people to do a CFIM protocol on all fallopian tubes. Hospitals can't afford to do that, so they will be missed.
Thank you. Then another question from Dr. Khan saying, thanks for the fascinating talk. Do you have any insight on the immune landscape that is associated with gynecological cancers?
So this is obviously important. There are lots of people who study immune landscape, and so I tend not to focus on it, because I know others are doing great work on that. When the potential of using drugs to modulate immune responses was becoming available, people assumed that after melanoma, high-grade serous ovarian cancer would be the cancer, which this would have a big effect. And it was incredibly disappointing. They thought it would have an effect because of George Koukis's paper showing immune infiltrates are prognostic, but checkpoint inhibitors alone don't seem to work. They do, of course, help for MSI positive endometrioid carcinomas of uterus and ovary. We know poly cancers probably don't need treatments, but they would work for there if they needed treatment. So the immune environment is obviously really, it's important. Immune infiltrates and the density and the location of immune cells seem to be prognostic, but they have not been effectively harnessed yet for the treatment. And there's a lot of work still going on with that, looking at development of CAR T cell treatment for high-grade serous ovarian cancer. But it's curious that this cancer, which isn't really a point mutation cancer, it's a aneuploid cancer, and perhaps creates less antigenicity, seems to be refractory to single agent checkpoint inhibitor therapy.
Right. Thank you. Okay, so that was the last of the questions. And I think with that, we'll probably leave it there. Thank you very much, David. And I hope you don't mind if people want to reach out to you and ask questions via email, if that would be okay with yourself.
I would love it. If anyone wants to collaborate or work with us at this Ovarian Cancer Observatory, we'd love to work with you. And thank you for inviting me to this rounds, because it gives me an opportunity to thank your organization for hosting the Journal of Pathology, which has been a huge part of my professional life.
Thank you. And just also to remind everybody that David's talk and other previous Grand Round lectures are available on the Pathological Society website, and we'll provide the link for that. But also just to point out that we have in November, we have our next Grand Round speaker is Dr. Samra Duralchik, who is based in London. She's an academic clinician, medical oncologist, and her talk will be is titled "At the Intersection of Tumor Evolution and Pathology." This will be back at the usual time at 9 o'clock on Wednesday, the 13th of November. But so I hope to see many of you there. And just one last thank you to David, who got up very early to give us this talk, and is now probably on his way to work, and will be doing the usual diagnostic work that we all are continually combating. So thank you very much, David, and thank you all very much for your attention. And yes, as I said, please look at our website for this Grand Rounds lecture and the previous ones, which are all recorded. Thank you very much. Okay, bye then.